Pathology, ocular oncology, orbit and oculoplasty. So we have wonderful array of cases. I'm sure every case is going to be a learning. You know, I love presentations with case because you get to learn a lot, all right, rather than didactic lectures, and that's what we are going to go through now. I'm honored to have Dr. Y. Sujata as the chairperson here. We do have our co-chairperson, Dr. Kasturi, awaiting her. I will be the convener, and my co-convener is Uma Maheshwari, and the moderator is Abhijit Beniwal. Do we have Dr. Abhijit here? All right. Since it's time on, let's start. Yeah. So our first presenter is Subhav Prashad, ocular tumor with a German's touch. Do we have the mark lists? Oh, it's not a conference, it's just a presentation. Okay.
Yes. Okay. A very good afternoon, and thank you for this opportunity to speak here at this forum. Ocular tumor with a German's touch. Be mindful of the color used here, and by the end of this topic, probably you will be able to decipher as to why this color code has been used for this. So, in the 20th century, the country which captivated the mind of every individual was Germany. And with Germany, everybody thought of two things: automobiles, probably Volkswagens, probably BMWs, and one another historical personality, Adolf Hitler. So why is Germany so important in ophthalmology? That also can be decoded by the end of this lecture. So today we have a young lady, 40-year-old, presenting to us with a mass which is painless, progressive, with a history of 2 years in the right eye, on the bulbar surface of the white part of the eye in the temporal quadrant, as one can see. So in a busy ocular oncology OPD, when you get these beautiful looking lesions to the eye of a surgeon in the OPD, and you're pretty confused with each of these cases being in different rooms, then how do you go about in a systematic manner? What is taught to us when we learn the letters of the English alphabet is also to draw neatly, and that also becomes a part of a practice, right? So the kindergarten saga continues even now. So what do you see and how do we describe this? It is in the interpalpebral location. It is a nodular lesion of so-and-so measurement. It is yellowish pink, semi-translucent, smooth surface, no surface keratin, note that. Intrinsic vascularity, yes, appreciable. Non-tender and no scleral fixity, dilated conjunctival and episcleral vessels. So what do we do to decide upon the plane of the lesion? Clinically, yes, an epibulbar mass, but what can help us further is an imaging, which is an anterior segment OCT. It shows a clear transition zone between the limbus and the lesion and a homogeneous course with minimal backshadowing. What would be the master plan? Because the definitive diagnosis is always histopathological, what better than to put the lumbricals of an expert to work? We did this, and after having delineated and marked 4 mm clinically clear margin, and at the point of separation of the adherent versus the relatively free conjunctival surface, incision made with a monopolar radiofrequency electrode, we went ahead, completely excised the mass, reconstructed the ocular surface with the amniotic membrane graft, and histopathological examination showed us that there is a lesion in the stroma of the conjunctiva, but we did an immunohistochemistry panel on the advice of the pathologist. And what do we learn from it? In a multinucleated giant cells and pseudo-inclusion bodies, which show positivity with cluster differentiation 34 on IHC, this is like post-operative picture 4 weeks later. The diagnosis we conclude is to the conjunctival stromal tumor. But why is it so important? Is this the end of the road for us? Not really. It is a rare tumor of the mesenchymal origin, first described by Martin Herwig in Germany, and hence the name. The pathogenesis is linked to immunological basis owing to a conjunctival location and needs to be differentiated from myxoma, a part of the Carney's complex, as a more deleterious atrial myxoma can underlie an eye lesion. So how do we do that? This table basically helps us to go about it, to differentiate a myxoma from conjunctival stromal tumor, a pleomorphic lipoma, and also a sarcomatous transformation of the same. Myxoma is important for the life of an individual because you have a concurrent atrial myxoma as a part of the Carney's complex and also Zollinger-Ellison syndrome. And what can help us is on histopathology, if you do an immunohistochemistry, it can help us with the various markers available as shown. Location is the bulbar surface. Anterior segment OCT is a very, very useful tool in doing this. A complete excision with histopathological coupled with immunohistochemistry helps in clinging the diagnosis to us. And key is a systemic workup, not to look at the eye alone, but eye is a part of the body, so examine thoroughly. Thank you.
Thank you, Shubhav. Excellent case. Yeah, COST is a very rare tumor.
Yes.
And how many cases have been reported so far?
Ma'am, in our hospital, like 13, recently described entity in 2011.
Okay.
And in our hospital, we have come across 3 such cases.
How many cases?
3 in the series I've analyzed.
3 cases.
Yeah.
3 cases, yeah.
Yeah.
So you might have seen the surgical video that he showed. So we have many stromal tumors in the conjunctiva, right? Epithelial tumors are OSSN. So what you saw there was they actually released the epithelium, and then the stromal component of the tumor alone was excised. So there is no loss of conjunctiva there, right? Yeah.
Yes.
So such tumors which you, with slit lump examination and anterior segment OCT, if you find the tumor in the stromal location, you can always conserve the conjunctiva. You can just actually, elevate the conjunctiva, go to the stroma directly and then excise, and that's exactly what you did, yeah. So even sometimes with lymphoproliferative lesions are also stromal tumors. So you don't have to actually, lose the conjunctiva or excise the conjunctiva, epithelium, but make a flap, take out the stromal tumor, and then preserve the conjunctiva. Yeah. So that video was really nice. Thank you so much. Yeah.
Thank you, ma'am.
So we go on to the next presenter, Dr. Abhijit Beniwal, a rare case of intraocular mass in adolescent.
Good afternoon. I'll be presenting a rare case of intraocular mass in an adolescent. So, a 13-year-old male boy presented to outpatient department with a history of diminution of vision in right eye for 2 months, and no other significant history was there. On examination, in right eye, vision was inaccurate projection of rays in 2 quadrants, and in posterior segment, exudative retinal detachment could be seen, and faintly pigmented mass was seen inferiorly in the vitreous cavity, and media was hazy. So, an ultrasound was performed, and a mushroom-shaped lesion with homogeneous moderate amplitude spike filling nearly the entire vitreous cavity with overlying retinal detachment was seen. Apical thickness of mass was 16.8 and largest basal diameter was around 13.5 as can be seen in this picture, and classic decrescendo sign is seen, and CMRI was observed, and T1 image showed brightly enhancing lesion and T2 image showed hypointense mass involving 2/3 of the globe reaching up to the posterior capsule of the lens. And a PET CT was done to rule out systemic metastasis. The differentials were thought of, it was quite a clear-cut diagnosis. However, the retinoblastoma is ruled out because of lack of calcification, unilateral presentation. Age was not typical. Metastasis were ruled out by PET CT. And for melanocytoma, the size of lesion was not in favor, and the lesion had low internal reflectivity, unlike melanocytoma. So patient was diagnosed at right eye large choroidal melanoma with exudative retinal detachment, T4A, and planned for right eye enucleation under general anesthesia. Visual evoked response was done and no significant response was seen. And after written informed consent, it was enucleated with insertion of 20 mm PMMA implant, and enucleated glove was sent for histopathology. This is the intraoperative image showing the retinal vessels behind the lens. And histopathological section shows cornea, iris and melanotic tissue. And this is 20x image showing spindle cell melanoma with grade 1, grade G1 on histology. Why it was atypical? The age of presentation was very young. The median age for the tumor is around 6 decades, and it advanced quickly over 2 months. And also it was a posterior uveal melanoma. At this age, more of the iris tumors have been seen. And patient was doing well till last follow-up, 6 weeks after surgery with prosthetic eye. So this is a paper which shows that less than 1% of uveal melanoma occur in young people, and overall incidence is just 4.3 per million. And it is observed that posterior uveal melanoma manifests preferentially during or after puberty, as also seen in our case. The child presented with just 2 months of diminution of vision. This could be associated with growth hormone spurt. So this is a study by Singh et al. Showing the incidence per million age-wise. And many studies have concluded that pediatric and adult melanoma are similar in prognosis or clinical appearance, and the treatment is essentially similar. And chromosomal mutations in young patients found that majority of these patients had disomy 3, and which is correlated with good survival outcome. Monosomy 3, 8q gain correspond to highest risk of metastasis. So my take home message is choroidal melanoma can present in young age and high clinical suspicion is needed. Thank you.
Abhijit, excellent case. I have 2 questions for you here. I understand you have done a PET scan.
Yeah.
You did a PET scan to
Yeah.
rule out systemic metastatic lesion. Did you have a FDG uptake in this lesion?
There was.
There was. So right there you know that it was a choroidal melanoma,
Yeah.
even clinically, even without histopathologically. A genetic testing was done in this case?
Sorry?
A genetic testing was done in this case?
H&D. Genetic.
Yeah.
Genetic? No, not in this case. The patient was not affording.
Not affordable. Okay, all right. Because he's very young, and it's good to
Yeah.
know, because we all know that prognosis of choroidal melanoma also depends upon the size of the lesion,
Yeah.
apart from the genetic markers, right? So there is this atlas which has come up where there are so many criterias, not only the size, but the mutations which is involved, yeah. But yeah, if patient cannot afford, maybe you can go in for some study or request some, MedGenome does it. If it's a very rare case, MedGenome is a company who does genetic testing. They do it free of cost. Even if you have your specimen available with your pathologist, you can still do it. You can actually do an MLPA, take out RNA and DNA from the same specimen, even a fixed specimen.
What is
It
the
will be
name
good to
of
know.
company?
MedGenome, MEDGENOME. They actually, rare cases, they would definitely do it free of cost. So you can just write it to them. I can give you the mail ID. And it's good to know that, because he's such a young patient,
Yeah.
and he has so many years in front of him to live, so it's good to know what the tumor is. Thank you so much. Yeah. Do you want to invite the next speaker?
The next speaker would be Dr. Krishna Teja Palla. Is he available? Yeah, please.
So, good afternoon, everyone. So, myself, Dr. Krishna Teja, I'm consultant via surgery at Shankar Foundation Eye Hospital. So, today I'm going to present a case of 33-year-old female who presented with painless blurring of vision in both eyes since 1 month. Her best corrected visual acuity is 612 in both eyes. Anterior segment examination was normal, whereas posterior segment examination showed hyperemic disc edema with flame-shaped hemorrhages in both the eyes, with macular edema, especially in the nasal macula, and small round hypopigmented subretinal lesions were seen at and around the fovea in both the eyes, and OCT showed neurosensory detachment along with the hyperreflective foci between NSD and RPE in both the eyes. So this is the OCT of the respect. And I made a provisional diagnosis of query neuroretinitis and advised the relevant investigations and started on tab-Bactrim DS BD for 1 week and stopped later. And 4 days later, she presented with the investigation reports. So hemoglobin was 7.1 grams and smear showed moderate anisocytosis along with hypochromasia, and MRI showed empty cella, and visual field showed bitemporal hemianopic field effects in both eyes. And rest of the investigations turned out to be normal. And provisional diagnosis of established papilledema due to query IIH was made along with anemia and empty cella, and referred to neurologist, so who measured the CSF opening pressure, and it was found out to be very high, that is 370 millimeters of mercury, and analysis was normal. And few small vessel ischemic changes were seen in the fresh MRI, and started on oral glycerol 20 ml TDS. So in spite of repeated insist on anemic correction, she didn't get it done. Now we re-insisted again. So later on she went to physician, and 2 whole units of blood transfusion was done. Now hemoglobin improved from 7 to 10 grams, and within a month again it dropped back to 7. And again the same cycle was repeated. So then physician felt suspicious, and he advised bone marrow aspirate examination, where pancytopenia was found out, and immunohistopathology showed plasmacytoblasts. And then FTG PET scan was done, so, and it turned out to be active multiple myeloma. And she was started on chemotherapy, and she completed 8 cycles by June 2023, that is within a span of 6 months. And this picture clearly shows this was the picture before starting chemotherapy, and this is after. So very well resolving disc edema along with macular edema is seen in the both eyes. And in the OCT also, NSD got completely resolved, and hyperreflective foci also got resolved in both eyes. And comprehensive quantitative serum panel showed monoclonal gammopathy with heavy chain of IgG and light chain of kappa. And on her final visit, ocular condition was stable and she was in remission. So this was the thing, and few other case reports which were published in 2011. So case 1 showed a Greek woman, 82-year-old. Her vision is hand movements in right eye with high IOP and history of stage 3 myeloma. She showed a superiotemporal quadrant plasmacytoma in the right eye, and here we are able to see the involvement of iris and ciliary body, and iris neovascularization is also seen, and ultrasonography showed infiltration of the plasmacytomas. And gonioscopy, complete obscuration was seen by the tumor, and biopsy and histopath analysis confirmed the multiple myeloma, and she was started on external beam radiotherapy, but she died due to systemic complications after a month. And another case report, here we are able to see one pedunculated mass in the left eye superiotemporal quadrant, and there is no intraocular extension in this case, I mean intraocularly. And so chemo was started for the case after confirming with the biopsy and histopath analysis. But again after 3 months, she presented with diplopia vision. So then on evaluation, we are able to see the retrobulbar tumor in this case, but there is no intraocular extension. And CT showed intraconal plasmacytomas. One is between superior and medial rectus, another one is between medial and inferior rectus in this case. So she was given both the combination treatment, and it got subsided, but she died after 5 months. And one more case is the man of 76-year-old Italian man, and who presented with painful decrease of vision in both eyes. And the same thing, but here in this case, the greater wing of sphenoid also got involved in this case, and he was started on the combination of external beam radiotherapy along with chemotherapy. And after 2 months of treatment, patient recovered well. So take home message, don't neglect the subtle clinical findings like anemia in this case. And each and every case needs thorough ocular along with systemic evaluation, which may help in diagnosing life-threatening conditions in our ophthalmology OPD itself. And rare conditions are seen rarely, but you might be the person. Thank you.
Thank you. Excellent case. When I was just thinking retrospectively, probably whenever there is a pancytopenia anemia, maybe a bone marrow biopsy would have given it away right from the beginning,
Actually,
right?
I couldn't get all the exact reports, man.
Uh-huh.
So, but oncology, when I had a word with him, they said they have already performed it. But
Before also, but
Yeah,
they
yeah.
couldn't.
Yeah.
They couldn't get plasmacytoma as a diagnosis at that point of time.
when we referred back, ma'am, especially after the physician evaluation,
Uh-huh.
so when they got referred, along with the FTG PET scan, that was also done.
Okay.
Yeah.
Okay.
But I couldn't get the report, so that's why I didn't document.
Uh-huh.
Yeah.
No, what I meant initially, they did only peripheral smear.
Yes, ma'am. That was done by the physician.
Correct.
But when the
correct.
patient was referred to the oncologist, they have
They
performed
didn't. They have done it,
But I
yeah.
couldn't get those reports, so that's why I couldn't add it.
Right,
Yes.
right. Can you show the fundus picture? Just a question to the students here. It's a differential diagnosis. Oh, can we have the presentation on for a minute? Difficult? Yeah. What are the other differential diagnoses that you would think of? It's a nice picture. This optic disc. Differential diagnosis. This is a very, very rare case and it's an amazing case. But if something comes like this, what else would you think?
They can describe first of all.
Yeah, right.
What are the findings you are seeing?
Shubha, do you want to take this up? Because you're a fellow. Most of them are postgraduates. Yeah, I mean something that which very strikes. We always think of leukemia and other rare things. Optic disc nerve drusense. Sometimes really presents like this irregular, elevated optic disc. So it's always good to do an ultrasound B scan. Okay, that just gives away the diagnosis. So never forget one of the differential diagnoses when you get a very crowded, elevated disc bilaterally, almost symmetrical. Think of optic nerve head drusen. Ultrasound B scan gives you the diagnosis. But well, this is a very rare, interesting case, just for a discussion. Thank you so
Thank you.
much.
Thank
Thanks a lot, yeah. So we go on to the next presentation by Dr. Disha Samantare. Yeah. It's a capillary hemangioma with secondary glaucoma in a 13-year-old male. A rare case discussion. Over to you, Dr. Disha. Welcome.
Good afternoon, everyone. I'm Dr. Disha Samantrai, here to present my case on capillary hemangioma with secondary glaucoma. I don't have any financial interest to disclose. To begin with, capillary hemangioma is a benign hematomatous vascular neoplasm of the orbit, which arises de novo and then undergoes clonal proliferation. They do not have any hereditary association, but 80% of them are known to resolve spontaneously by 7 years of age. And they have a female to male preponderance of 3:1. They're not present at birth, but they appear within the first few months of life and then gradually progress to a soft and spongy mass, which may blanch on pressure, but without any pulsation or bruit. They come in two phases. First, the proliferation phase from 3 to 12 months of age, where there will be vascular endothelial cell proliferations, which cause the formation of new vessels as well as anastomosing vascular channels. This leads to a mass which we typically know as the strawberry nevus. That is followed by the involution phase, which comes after 3 years of age, where all of this is replaced by fibrous tissue and hyalinization of the capillaries. The most common complication is usually ulceration and bleeding from the lesion. Coming to my case report, a 13-year-old male child presented to the OPD with a 4 into 3 centimeter soft, compressible, non-fluctuating swelling with ill-defined margins over the right upper eyelid extending towards the forehead that first appeared after 2 years of age and then became gradually progressive. There was recent development of nodular cystic lesions bleeding from its surface. And there was also a similar history of swelling in the right nasal cavity, which was associated with epistaxis until 5 years of age, after which it was spontaneously regressed. These are the pictures. So, for investigations that we did, the best corrected visual acuity in the right eye was 6/36 partial, and the left eye was 6/6. The extraocular movements were free and full in the left eye, but were restricted in the upward direction in the right eye because of the mechanical ptosis. On slit lamp examination, the bulbar conjunctiva, cornea, anterior chamber, and pupil of both the eyes appeared to be normal. The intraocular pressure of the right eye was 22 millimeters of mercury, and for left eye was 17 millimeters of mercury, measured by NCT at 12 p.m. On fundoscopic examination with indirect ophthalmoscope, the media was clear, CDR was 0.6 with deep cup and inferior notching of vessels in both the eyes. And on ocular coherence tomography, we found retinal nerve fiber layer thinning, which was in the inferotemporal area in the right eye only. We also did repeated HVF24/2 visual field analysis for this patient, but it did not yield any appropriate results as the patient was uncooperative due to the lid mass. On ultrasonography and CT of the nose and orbit, we found many heterogeneous soft tissue growth with multiple feeding channels from the superior ophthalmic, superficial temporal, and retromandibular vessels. The vitals of the patient were normal, so were the ultrasonography of abdomen, pelvis, MRI of neck vessels, and MRI of brain. But the patient had a history of severe anemia at 4 years of age with 1 episode of blood transfusion. The child was put on oral propranolol tablets 10 mg twice daily after food since 5 years. He was also started on timolol 0.5% eye drops twice daily. He underwent partial surgical debulking of the swelling under general anesthesia and also has been advised to repeat surgery after 6 months. The histopathology examination from the surgery revealed it to be a capillary hemangioma. Post-operatively, 2 months later, we found that there was no further bleeding from the lesion. The visual acuity also stood corrected at 6/9 best corrected visual acuity with refractive management, and the right eye IOP was also reduced to 14 millimeters of mercury, but the fundoscopic picture had no significant changes. These are the post-operative images. Now, capillary hemangioma can be divided into superficial, deep, and mixed lesions, in which the superficial is the visible mass producing astigmatism and amblyopia because of the pressure. The deep lesion usually produces strabismus or decreased vision due to pressure on the optic nerve, and it can be mixed type. The possible mechanisms of glaucoma in this case could be mechanical pressure on the globe because of elevated episcleral venous pressure or malformation of the anterior angle chamber. And there can be pressure on the optic nerve, which can lead to optic atrophy. There are multiple systemic associations associated with capillary hemangioma, which can be other hemangiomas in the head and neck region, Maffucci syndrome, which is associated with multiple enchondromas and visceral hemangiomas, Cassibach-Merritt syndrome, which is a consumptive coagulopathy associated with the capillary hemangiomas in head and neck area, and also Faces syndrome. These are the differential diagnoses possible for my case, which include cavernous hemangioma, Sturge-Weber syndrome, Kaposi hemangioendothelioma, telangiectasias, and other carcinomas like squamous cell or metastatic carcinomas. So to conclude my case, I would like to say that with the targeted management of beta blockers as well as surgery, these complications of bleeding, raised intraocular pressure, and decreased vision were found to have reduced in this case. So even though capillary hemangioma is one of the most common benign childhood tumors and do not require any treatment in case of absence of complications, but we must individualize the treatment and cannot go for wait and watch for every case, as active management is required for progressive cases of capillary hemangioma such as this. These are my references. Thank you all.
Yeah, so Disha, thank you for being here and presenting an amazing case. So whenever we talk about oral propranolol, the indication of oral propranolol is during the proliferative phase. Yes. So he was a 13-year-old?
Yes, ma'am.
And he was on propranolol for 5 years?
Yes, ma'am.
Right, yeah. So that is something probably, the proliferative phase is the initial phase.
Yes,
and that's when the oral propranolol works.
Yes, ma'am.
So it doesn't work otherwise, he's 13-year-old, right? Yeah,
Yes,
so probably oral propranolol was not the right indication in this particular case. And it's been going on for 5 years, right? We don't give propranolol for this long, okay? So oral propranolol works in the proliferative phase. That is one take-home message. Did you consider triamcinolone, steroid injection, intralesional injection in this case?
Actually, madam, this patient presented to us in the very later phase of his life, after he had turned 13 years, and the lesion existed since he was 2 years of age.
Huh.
And because of the continuous bleeding from the lesions that had developed, he was already advised for oral propranolol from outside and no other.
No, did you consider
intralesional.
injection? Was that a consideration when you were
Yes,
thinking
ma'am.
of the management?
Yes, ma'am, we were considering intralesional.
Was it
steroids,
given?
But, so
Intralesional triamcinolone acetonide was given?
no, ma'am, it was
you
not
did the,
given. Because of the
surgical.
active bleeding only, we wanted to wait a little before we can go for intralesional triamcinolone. But then he preferred to go for debulking surgery, which was done in association with the plastic surgery department.
Okay, that's good, but bleeding doesn't stop you from injecting. You know, you can always go for an intralesional. That is one of the treatment modality for capillary hemangioma that we practice. Yeah, thank you so very much. Thank you. Yeah, right. So we go on to the next speaker, Dr. Rashi Latigara, subconjunctival cavernous hemangioma in a young adult male.
Good afternoon, everyone. So,
Can we have the presentation on, please? Thank you.
so patient details, 18-year-old male student who is a resident of Greater Noida presented to our outpatient department with chief complaints of foreign body sensation and painless progressive red mass in his left eye 2 months ago. There was no history of trauma, nodular lesions, cough, fever, swelling elsewhere, weight loss or any similar lesion. Personal history was fine. Medical history, surgical history, systemic examination was unremarkable and his general condition was good. Anterior segment examination was unremarkable for both the eyes. In left eye, in conjunctiva, there was a multilobulated bright red, smooth and vascular lesion measuring approximately 5 into 5 into 4 with tortuous dilated and engorged vessels at the base of lesion in the infratemporal region. The lesion was mobile with conjunctiva and it was non-pulsatile. It was not increasing in size with Valsalva maneuver. So this was the lesion. Fundus examination was unremarkable, both eyes. So we did few investigations. We did complete blood count, we did tridot, we did chest X-ray and Muntux, and we did B-scan to rule out any posterior involvement. Provisional diagnosis that we considered in this case was infratemporal subconjunctival cavernous hemangioma of left eye. So management, in many studies a trial of subcutaneous or topical propranolol was given and the lesion has shown regression. So we gave the trial of topical timolol eye drops BD for 2 months, but there was no regression. These are the few studies. One study was published in Ophthalmology in German journal, where it stated that beta adenoreceptors are involved in tumor growth and proliferation of new blood vessels. So they have given beta blockers and the lesion has showed regression, but it didn't work in our case. So then we went for surgical excision using no-touch technique under topical anesthesia, and we noted that there was no extension beyond Tenon's capsule. Histopathological examination of the lesion revealed a cavernous hemangioma of the bulbar conjunctiva. This was the image that was acquired 1 day after the excision of lesion, and histopathological evaluation showed multiple blood-filled cavernous spaces surrounded by a fibromyxoid stroma. So the differential diagnosis that we considered in this case was, first is conjunctival capillary hemangioma, that is known as strawberry nevi, but the presentation of capillary hemangioma mostly is in the first 6 weeks of life and it regresses spontaneously. Then we considered conjunctival papilloma, but HPV, but there was no, we couldn't do the pap test, but we thought that it is mostly flat, it has mostly flat base. So then third, we ruled out pyogenic granuloma by doing chest X-ray and Muntux test, and the lesion was not very vascular and didn't bleed on touch. Then fourth we ruled out was lymphangioma, but because there was no deeper orbital component, so we ruled out that, and also it wasn't presenting since birth. Fifth, we ruled out Racim's hemangioma, which is normally associated with Weber-Mason syndrome. And sixth, because it was not increasing in size with Verix, with Valsalva, so we ruled out Verix. This is it.
Thank you. Excellent presentation. Ma'am, do you have any comments? Yeah, all right. It's really nice. It's rare again. So this is kind of an acquired capillary hemangioma, which was not congenital or infantile hemangioma. So when you talk about pyogenic granuloma, it's just a differential diagnosis for a discussion. You wrote TB and sarcoidosis in bracket.
Yes.
Why?
Ma'am, because pyogenic granuloma is mostly associated with tuberculosis or sarcoid disease.
No, that is wrong. So first of all, pyogenic granuloma is a misnomer.
Okay.
It's neither pyogenic, neither granulomatous. Pyogenic granuloma. Pyogenic granuloma is an hyperplastic granulation tissue.
Okay.
Okay. Now granulomas are separate. So that is when you write only granuloma there, then you can think of tuberculosis or sarcoidosis.
Okay.
I don't know whether it's a typo error, but pyogenic granuloma is a hyperplastic granulation tissue. Usually it happens when there is a hidden foreign body and then there is lots of, even if you leave behind a suture, like a vital suture is remaining there for a long time, you get lot of, granulation tissue around it. Post-surgical, you can have granulation tissue around it. Exactly, so that is pyogenic granuloma. In fact, we should stop using the word pyogenic granuloma. There is no pus there is no granuloma there, okay? Now, when you talk about TB and sarcoidosis, it is granuloma.
Okay.
Necrotizing granuloma or non-necrotizing granuloma. So just to point out, otherwise excellent presentation. Thank you for sharing it here. Do you have any comments? Right. So we go out to the next speaker, Vishal Prakash Nandeshwar. We have Dr. Vishal here. Yeah. So he's going to present us a rare case of subconjunctival mass by dirofilareal repens. So that's going to be interesting. You have videos? Vishal, video also?
Yes, ma'am.
Awesome, yeah. Go ahead.
Good afternoon, everyone. Myself, Dr. Vishal Prakash Nandeshwar, presenting the rare case of subconjunctival mass by dirofilareal repens from the Western Odisha case report. Introduction: dogs and other carnivores in Southern Europe, Africa and Asia are affected by the zoonotic filarial worm Dirophilia repens. Mosquito transmitted microfilariae mature into fertile microfilariae in the definitive host. Human infection can occur. The skin, lungs, eyes, female breast, and male genitalia are among the often impacted organs. Within its accidental human host, the parasite typically remains infertile. Contrary to instances of ocular loasis in which the loa worm is the infectious parasite, systemic antifilarial therapy is often not required. Coming to case of 47 years old female from Rourkela, Odisha came to IOPD of Ispat General Hospital, Rourkela with complaints of pain, conjunctival redness, swelling and sensation of having a foreign body in the conjunctiva of her left eye. She has a history of having pets like dogs and cats at her home. On examination, visual acuity was uncorrected 6/9 and in both eyes with pinhole 6/6 in both eyes. Initially, she was diagnosed with episcleritis following treatment with the topical antibiotics and steroids and reviewed after 3 days with no improvement. On external examination, left eye shows conjunctival congestion on the nasal part of left eye over bulbar conjunctiva. It shows solitary subconjunctival whitish vermiform mobile mass moving worm in the nasal part of the left eye. On slit lamp examination, the left eye shows no cells and flare in the anterior chamber. It shows solitary subconjunctival whitish vermiform mobile mass moving worm in the nasal part of the left eye. In right eye was within normal limits. Fundus examination was within normal limits in both eyes. Coming to management, as a specimen of the worm was yet to be identified, patient was prescribed antihelminthic drugs, ivermectin and albendazole. Surgical removal was performed under local anesthesia with a small incision over conjunctiva, exposing worm. Whole parasite was removed with a piece of conjunctiva and extracted worm was preserved in a 10% formalin, then sent for microbiological confirmation. Here we can see the worm is extracting. After microbiological examination, grossly the worm was slender, about 6.5 centimeter in length. Histopathological sections of the worm showed thick cuticle with external longitudinal cuticular ridges and a thick muscle layer. Based on the morphological features, the worm was identified as a Dirophilia repens. Patient was monitored with a proper follow-up of 7 days and then 1 month. My conclusion is that Dirophilia infections due to Dirophilia repens appear to be increasing all over India and throughout the world, suggesting the need for high suspicion, prompt diagnosis and management. Thank you.
Where else it can go inside the eye? Other report shows
Yes, ma'am.
this worm can penetrate inside the intraocularly
Subconjunctiva and
common sites or something.
subcutaneous भी होता है.
Subcutaneous.
Subcutaneous.
No intraocular cases.
I have not seen.
Intraocular cases of dirophilarias also, and as an oculoplasty ma'am would agree, eyelid surgeons, we do see it in the orbit and subcutaneous tissue also. So yeah, especially in South India, it's more common. Yeah.
Yes.
Thanks for sharing the video. I saw the PGs like doing. Yeah, you have not seen it. First time you're seeing it. Yeah. Who all have seen dirophilariasis here in the audience? She was like surprised. She's like, ee. Yeah. No, first time. Yeah. So it's very common in South India. You know, you can take it from subconjunctival. There is intraretinal worms can be there in the orbit, subcutaneous in the eyelid. Yeah. So they present, if it's subcutaneous, they present as acute preseptal cellulitis kind of a picture. Yeah. Interesting. Thank you, sir.
Treatment available?
Yeah.
Post-testing.
Ma'am, in Dirophilia repens, in case of Dirophilia repens, ivermectin albendazole doesn't work. Through review of literature, it doesn't work.
Yeah. So eyelid orbit, we use albendazole, a tablet, and then in combination with steroids because
Yes.
it leaves behind a lot of inflammation also. So that's the combination that we give. Yeah. Thank you. We go on to the next presenter. We have Lavanya Maddi here. Yeah. So she's gonna present on something sinister in the sclera. Inconclusive biopsy. What next? It's a lot of secret. Yeah, all right. It's a mystery case.
Not moving. Yeah. So good afternoon everyone, I am Lavanya Maddi and I will be presenting on behalf of Operation Eyesight Universal Institute for Eye Cancer, LV Prasad Eye Institute. These are the abbreviations used in the presentation. A 20-year-old lady from Visakhapatnam presented with the complaints of redness in right eye since 2 months. She was treated elsewhere as right eye scleritis with topical steroid eye drops for a month without resolution of her symptoms. On examination, her visual acuity in both eyes was 20/20. In the left eye was within normal limits. In the right eye, there was an elevated nodular pale pink lesion extending from 12 to 5:30 clock hours with prominent episcleral vessels. So with the provisional diagnosis of nodular anterior non-necrotizing scleritis, the connective tissue disease profile was advised and she was asked to continue on the topical steroids which she was using. So the CTD profile was within normal limits and patient was asked to use oral steroids in tapering doses. After 1 month of steroids, clinically the lesion became more diffuse. Sorry, the clinical photograph is not available. The fundus examination and FFA were within normal limits. However, in B scan, there is subtenon fluid in the right eye and left eye was normal. So as the lesion was diffuse in clinical examination with the suspicion of extraocular or orbital lesion, she was advised to take oculoplasty opinion and was asked to taper the oral steroids. But the patient did not review as advised and she came after 12 weeks of partially compliant on and off oral steroids. Surprisingly, the lesion was much flatter with minimal congestion and she was continued on topical NSAID eye drops. After 2 weeks, she came with the recurrence of redness in the right eye and on examination there was an elevated pale pink lesion from 12 to 3 clock hours and she was advised to undergo CT orbits. Patient was lost to follow-up for 3 months and 3 months later she presented with the lesion extending from 10 to 5 clock hours. This time there was mild proptosis of right eye and fundus examination showed ILM folds. ASOCT through the lesion showed that the lesion is subepithelial in location. And macular OCT showed elevation of posterior pole corresponding to the ileum folds. CT orbit showed soft tissue densities molding around the right globe with a significant retrobulbar component possibly causing the elevation of the posterior pole. At this point of time, our differential diagnoses were periocular lymphoma, anterior nonspecific orbital inflammation or sarcoidosis. Serum ACE and IgG4 were normal and patient was advised incisional biopsy. The incisional biopsy showed predominantly crush artifacts due to which the morphology of normal or abnormal cells were not identified. The Ki index of these cells was less than 1% and these crushed cells were positive for CD45. However, the biopsy was inconclusive and was advised to get repeat biopsy. While awaiting the HPE and IHC reports, the lesion became more diffuse with chemosis and proptosis increased and the extraocular movements limitation were also increased. In the repeat incisional biopsy, H&E stain showed round cells with crushed artifacts and IHC markers, cytokeratin, desmin, TDT and CD20 were negative. MPO was strongly positive and these cells are also positive for CD34 and CD45. This time the Ki67 index is high. With all this, the IHC report was extramedullary myeloid sarcoma. So, myeloid sarcoma is an extramedullary solid tumor that's caused by an abnormal proliferation of immature precursors of white blood cells. Orbital involvement is very rare and primary orbital involvement without a systemic disease is even rarer. So, we went ahead and advised bone marrow biopsy, complete blood workup and whole body PET CT. Bone marrow biopsy and blood workup was within normal limits and PET CT showed hypometabolic uptake in right periocular region and no other metabolically active lesion elsewhere. So our final diagnosis is extramedullary isolated myeloid sarcoma, for which the intravenous chemotherapy was advised by the oncologist, and after completion of chemotherapy, there was resolution of lesion with no proptosis and improvement of extraocular muscles. And the CT imaging after chemotherapy showed only residual periocular thickening, and the PET CT does not show any metabolically active lesions. So there are cases where the reported anterior and posterior scleritis in an AML case, and they hypothesized that it's due to reactive anti-leukemic inflammatory response. And in an article by Lee et al., he described about 9 cases of isolated myeloid sarcoma in which only 1 case showed orbit as a primary location. So to conclude, our patient presented with an elevated nodular lesion and subtenon fluid in subsequent follow-ups. After 12 weeks of steroids, the lesion significantly reduced, and after 2 weeks there was recurrence and she was lost to follow-up and later presented with a diffuse lesion and proptosis, and CT showed soft tissue densities around the globe. Initial incisional biopsy was inconclusive, and while awaiting the report there was progression of the disease, and repeat biopsy showed strong MPO positivity, and PET CT showed periocular metabolically active area, and the final diagnosis of extramedullary isolated myeloid sarcoma of orbit, which was treated with intravenous chemotherapy, showed resolution.
Final
Thank
outcome.
We are following up the case. Usually myeloid sarcoma of the orbit without systemic leukemia is very rare. So we are following up her in a 3-monthly basis. We are doing her peripheral blood smear every 3 months and then 6-monthly bone marrow biopsy. Till now she did not develop any systemic disease, and ocular examination wise she is normal both clinically and radiologically.
I have a question. So when she was diagnosed as scleritis, did she have pain?
Yes, initially she had pain. Actually, in the first presentation only, it was like scleritis. In next,
It was a painful nodule.
initially.
Okay.
in all the remaining presentations, it was not painful, and the lesion also did not look like scleritis.
Right, yeah, because scleritis will have typical
Yes.
pain and, so sometimes we see this lymphoproliferative lesion which actually presents
Yes.
clinically as, but then pain is the catch thing. If there is no pain, it's not scleritis.
Yes.
If there is pain, it's scleritis, and if there is no pain, then we usually think of something else. This is out of my curiosity. I have never seen a primary extra.
Yes, that's why we actually reviewed the literature and found out that there are cases which presented as scleritis in AML, which were hypothesized to be due to anti-leukemic inflammatory response.
All right, yeah.
Unfortunately, we don't have the clinical photo of the second presentation.
Okay.
It was seen in the retina department till then. When the lesion was not painful and it's more diffuse and not looking like scleritis, then
that's when it got, out of my curiosity, your radiation and medical oncologist, having a very localized disease, would radiation be an option in this case? Was it discussed rather than going for a systemic chemotherapy?
Actually, as per the literature, myeloid sarcoma, usually it presents as a precursor to systemic leukemia. So our treating oncologist, when we discussed with him, he said there are high chances of developing a systemic leukemia. So chemo is
it's better.
preferred.
Yeah, right. Yeah, but now so far she has no
In this
systemic
1 year,
involvement.
she did not
And
have it.
anyway, she received the chemotherapy also, right? Yeah. All right. Thank you so much. Very interesting case.
Thank you.
Right. So we go on to the next presenter, Dr. Subhav again on the podium. Mercedes-Benz of the orbit. All right.
The first one, not the second one. Okay, the second one, yeah, this is the second one. 2. Yeah. Also, can you, okay.
All right, so we'll call the next presenter. Perfect. So I'll have Rajneel Bhattacharjee, Dr. Rajneel Bhattacharjee, an unusual presentation of well-differentiated SCC of left upper eyelid. Over to you. We'll have the next presenter, please. Can we have Dr. Rajneel's presentation? Yeah, thank you.
Good afternoon, respected judges and everyone present. I am Dr. Rajneel Bhattacharjee, registered of Shilchar Medical College. Squamous cell carcinoma is a type of invasive malignant tumor which arises from the squamous cell layer of the epidermis. When it occurs in the ocular and periocular region, it can involve structures like conjunctiva, cornea, and eyelid. Squamous cell carcinoma presents as a range of progressively advancing malignancies from precursor actinic keratitis to in situ squamous cell carcinoma, invasive squamous cell carcinoma, and finally to metastatic squamous cell carcinomas. Squamous cell carcinoma commonly arises from the lid margin in elderly patients de novo or from existing lesions like actinic keratosis, Bowen's disease, radiation dermatosis, or immunosuppressive drugs. Histopathologic characteristics of squamous cell carcinoma depend on the degree of differentiation of the tumor. In well-differentiated squamous cell carcinoma, the cells are polygonal with abundant eosinophilic cytoplasm and prominent nuclei, dyskeratotic cells with characteristic keratin pearls and intercellular bridges. I present a 65-year-old female which presented to the ophthalmologic outpatient department with chief complaint of a growing mass on her left upper eyelid on the left eye for 6 years. On elaborate history taking from the patient, we found that the mass was initially the size of a pea but slowly increased to its current size over a period of 6 years. There was no history of associated pain or bleeding from the mass. There was difficulty in seeing from the left eye due to the mass obscuring her left eye. Ocular examination revealed a firm mass of size 3.5 into 3 centimeter into 2.5 centimeter involving left upper eyelid margin. It was non-tender and did not bleed on touch. However, brown and black hemorrhagic areas were seen on its outer surface. She had pseudophakia in her right eye and phakia in her left eye with visual acuity 612 and 618 in right and left eye respectively. Fundus examination was normal in both the retina. On general examination, there was no lymphadenopathy or organomegaly was noted. Her systemic examinations results were within normal values and no chronic illness. The differential diagnosis we consider were squamous cell carcinoma, sebaceous cell carcinoma, pyogenic granuloma were made. Routine blood investigations like blood sugar, virology, bleeding, ECG, chest X-ray, all other routine were normal. The excision was done with wide margin at the base under local anesthesia and the defect was closed directly. Post-operatively, there was some edema over the wound site and she was prescribed topical and systemic medications. From post-operative day 1, the patient got relief and could directly see. Histopathologic examination of the specimen showed well-differentiated squamous cell carcinoma. The margins were free from tumor. Follow-up was done at regular intervals and she improved. After 1 week, we can see she has drastically improved. So, the squamous cell carcinoma can be, the presentation can be varied, leading to difficulty in diagnosis clinically. The histopathological examination is mostly required for the correct diagnosis. A lot of studies have shown that clinical diagnosis can be inaccurate preoperatively. In one such study, squamous cell carcinoma of the skin diagnosed clinically was confirmed in just 51% of cases only. The treatment of eyelid tumors is varied and a lot of choices are present. The choice to follow is depending on the pathological process present. It includes surgical excision, cryotherapy, radiotherapy, electrofulguration, topical application of 5-FU, intranasal and bleomycin, corticosteroid, or different other techniques depending on the position and mainly on the size of the lesion. Interferon infiltration has also been used intralational along with laser surgery and photodynamic therapy. The advanced and extensive squamous cell carcinoma also requires systemic neoadjuvant chemotherapy or palliative chemotherapy. Although there have been very few studies to compare the efficacy of this treatment, the surgery and radiotherapy seem to be the methods most effective, and the surgical treatment is the procedure with the lowest rate of recurrences. The various techniques used in the treatment of eyelid tumors can lead to good cosmetic and functional result. Depending on the location, size and severity of the tumor, the results may range from a small scar to permanent changes in the structure of the eyeball. In our case, the large size of the tumor and its unique way of presentation on the upper eyelid was a rare scene. The mass was hanging down from the upper eyelid and completely obstructing the vision in the left eye. So it was our aim to surgically excise the whole tumor and give the patient some relief so that she can live her rest of her life disease-free. The case is show large squamous cell carcinoma, which is not very commonly seen in recent published literature. The patient presented to us with a large sized tumor after having it for a long term due to ignorance and lack of awareness of cancerous growth in the body. Early diagnosis and treatment reduce the morbidity and mortality of the patient, and the most important is to consider the possibility of a cancerous lesion in addition to benign conditions which we might miss. In a case of a collagen also may turn out to be squamous cell carcinoma, so we should always look for the possibility of a cancerous lesion even if we think it to be a benign lesion. Thank you.
How many of you routinely send collagen also to histopathological examination? Yeah? Recurrent cases you are sending. But age group also important. Above 50 or 55 years age, even without recurrence also, first time also, better to send the specimen for HPE, because thereby we can avoid all this. What do you say?
Ma'am, yeah, I mean, usually in recurrent cases, that's what I do in my practice, not in regular, and especially if it is an elderly age group. If it's a young patient, obviously not, but if it's an elderly age group. But there are situations where I have seen granulomas like chalazion, where it has turned out to be a TB granuloma also. So these things can also be ruled out in a very diffuse granuloma, which is slightly abnormally looking and not typically like a chalazion. Now,
When patient stay with the chalazion for years before getting it treated, so that long history, that does not need recurrences even, because the patient may be staying with the chalazion for 2 to 3 years like that. They stay without any treatment anyway, and when they present to us, and maybe by chance we suspect that it is maybe cancer, we send for histology and it might turn up. We have found a lot of cases like that actually.
right. Now, another thing that I really want to highlight here in your case is when we talk about squamous cell carcinoma, you said chalazion, sebaceous gland carcinoma. So what I want you to understand is there are cancers which arise from the anterior lamella. There are cancers of the eyelid which arise from the posterior lamella. Okay. In your case, it is purely anterior lamella. It is skin. All right.
Yeah.
So the cancers, which is rapidly growing, huge tumor, that you have to think about as a differential diagnosis is squamous cell carcinoma, keratoacanthoma, and basal cell carcinoma. All right. Now, when you talk about chalazion, it arises from posterior lamella. So the posterior lamella malignancy is usually sebaceous gland carcinoma. So when you talk about chalazion, it never is equal to a squamous cell carcinoma.
It's
All
different.
right? Yeah. When you talk about chalazion, the differential diagnosis of a malignant lethal eyelid tumor is sebaceous gland carcinoma. Yeah. So something hanging from the skin which is so large as in your case, which is obviously not too common, is squamous cell carcinoma or basal cell carcinoma or keratoacanthoma in our practice that we keep in mind, and it's all for the students, you know. So depending upon the location, whether it's anterior lamella or posterior lamella, you can actually have a differential diagnosis in your hand. Yeah, thank you.
Which is a better term, sebaceous gland carcinoma or meibomian gland carcinoma, or both are same?
It arises from the meibomian glands, but it can also arise from Zeiss glands. It can arise from caruncula. So a universal term would be a sebaceous gland carcinoma. But yeah, it is a sebaceous gland. Meibomian gland is in the tarsus. Zeiss gland is in the tarsal margin. Caruncle has sebaceous glands. So the generalized term is sebaceous gland carcinoma. Yeah, right. Thank you.
Thank you.
All right, I forgot. Shubha was the next presenter. I was going to call the next presenter. So, yeah, Shubha, all right, the second presentation.
Thank you once again. Very good afternoon. The case for presentation now is titled The Mercedes-Benz of the Orbit, and we shall still decipher it at the end of this presentation. I would thank my mentor and our ocular expert pathologist, Dr. Kaustubh, for giving us the most valuable inputs during this case. So what's the story for today? We have a middle-aged lady who presented with protrusion of the right eye since 3 months and diminution of vision in the right eye for distance and near for 6 weeks. And on our examination, we found a proptosis of 12 millimeters with a palpable mass in the superior temporal quadrant of the orbit, a dystopia of 3 millimeters, a positive pressure on retropulsion. More importantly, temporal fossa fullness, and it was negative for a bend valsalva, a thrill or a bruit ruling out a vascular lesion. This is a 9-gaze picture of the same patient showing restriction of ocular motility in all the gazes, and there was decrease in the corneal sensations and also the supraorbital sensation. Radiological evaluation to supplement our clinical acumen showed that there is an ill-defined mass in the intra and extracorneal space of the right orbit, where there is a breach and it involves the temporal fossa. And there is a focal erosion of the bony roof, and it is extending even involving the zygomatic arch, but there is no intracranial involvement. With this, we clinico-radiologically think that this is a lesion which is centered at the sphenoid trigone. And what are the possible differentials with lesions centered on the sphenoid trigone could be, one is it can be a sphenoid wing meningioma, second is orbital plasmacytoma, osteosarcoma, orbital metastasis, and barring this age group, it would be a primary neuroendocrine tumor. So when in doubt, it is always best to think calmly, and then we proceed with a more definitive diagnosis. We went ahead with a biopsy via the superior subbrow transperiosteal approach, which is a multi-level incision biopsy to involve the epicenter of the lesion. And this is the pre and post-operative photograph of the same patient. On biopsy, what we find are plasma cells. On immunohistochemistry, they were positive for the cluster differentiation 138 and negative for 23 and pan-cytokeratin. But is this the end of the road? Is just knowing that a plasma cell malignancy in the orbit enough, or do we investigate further? On systemic investigation, we have found that she had hypergammaglobulinemia, an M band, a bone marrow biopsy suggestive of plasma cells and the blast forms as well, and a whole body PET CT scan showed FDG avid lesion in the right orbit, axial and appendicular skeleton with lytic lesions. So drawing a leaf out of one of the presenters' presentation today on multiple myeloma, yes, I'm here again to present you the same. A multiple myeloma, probably the outward side of the coin. A multiple myeloma is a malignant proliferation of the plasma cells, monoclonal, and is the second most common hematological malignancy. And the orbital presentation might be the initial presentation of a much lurking malignancy like a multiple myeloma. So what do we know about it? Yes, it's an expansion and proliferation of the monoclonal plasma cells and increase in the osteoclastic activity, producing punched out lesions in the axial and appendicular skeleton. And bone pain can be the primary symptom of a patient presenting or already diagnosed with multiple myeloma. We have 65% of such subset of patients who are already diagnosed as multiple myeloma later on presenting with orbital involvement. So we have an isolated entity, a primary extramedullary and multiple myeloma. Funk's classification involves ocular, orbital and neuroophthalmic. Ocular and neuroophthalmic were presented just probably 35-40 minutes ago, and here I am with the orbital manifestation. The management protocol for the same involves treatment with proteasome inhibitors coupled with thalidomide and dexamethasone, and since there is hypercalcemia in this, we give zoledronic acid as well. The patient with us, she completed 8 cycles of target therapy, and on our follow-up visits, she's on a 10-month we followed up for now, 10 months is the latest, and she is doing well. In our case, she was a female, which is multiple myeloma is usually a disease with a higher male preponderance, and she was, the orbit was the initial presentation in her. We investigated her and we found that she had a much lurking malignancy like multiple myeloma. Thank you.
Thank you, Shubha. We are actually running short of time, so we'll have the discussion later.
Sure.
And I'm going
Thank
to
you.
call the next presenter, Dr. Disha Agarwal. Dr. Disha Agarwal. All right, Dr. Uma Maheshwari for the next presentation, proptosis and ominous masquerader. Do we have Shalin Shah here? Shalin Shah, hands up? No. Lakshmi S. Lakshmi is there. Lavanya is here. Harsha Chandran. Harsha Chandran is here. Amit Prasad is here.
Good afternoon, everyone. I am Dr. Uma Maheshwari, and the title of my case report is Proptosis and Ominous Masquerader. I have no financial interests. Proptosis is an abnormal prominence of the eyeball beyond the confines of the bony orbit. It can occur in various systemic as well as orbital disorders. Not only is proptosis vision threatening, but it also could be a harbinger of potentially fatal conditions. Here, we report a case of a 7-year-old boy who presented with rashes and bilateral sudden onset proptosis. So we had the 7-year-old male child presenting to the emergency room of a pediatric hospital in an unconscious state with chief complaints of rashes all over the body following using an antibiotic syrup. He had a history of high-grade fever with chills for 3 days. He was a known asthmatic. On general examination, the child had urticarial rashes all over the body. He was febrile with tachycardia and tachypnea. The blood pressure was on the lower side. Peripheral extremities were cool, and the child had reduced overall power tone. He was being treated as a case of anaphylactic shock due to a suspected drug allergy. Plain CT brain was normal. The child was intubated in view of poor general condition and was kept on ventilator. Ophthalmic opinion was sought for fundoscopy. On ophthalmic examination, we saw bilateral axial proptosis. Vision and extraocular movements couldn't be assessed due to the patient's state. Left pupil was mid-dilated and sluggishly reacting. Fundoscopy was normal. Contrast-enhanced CT brains in orbit was advised by us. In investigations, the coagulation profile was normal, thyroid profile was normal, inflammatory markers were elevated. However, CCT showed bilateral cavernous sinus thrombosis with the thrombosis extending into the left jugular vein. As you can see in the CT, the lateral walls of the cavernous sinus have become more convex, it's more prominent on the left side. The child was initially suspected to have anaphylactic shock and was being treated for the same. Later on, after the CCT report, the course of treatment changed. The child was now started on parenteral antibiotics with appropriate supportive measures like intravenous fluids, mannitol, steroids, and oxygen supplementation. Therapeutic dosage of enoxaparin was initiated with activated partial thromboplastin time monitoring. He was later switched to culture-sensitive antibiotics based on the blood culture, which was positive for Staphylococcus aureus. On day 7, the child's sensorium improved, although irritable. His unaided visual acuity could now be assessed, which was 6/12 in left eye and 6/6 in right eye. Proptosis reduced to some extent, although he had pain with eye movements. He also had left lateral rectus palsy, as you can see in the picture. After 2 months of anticoagulation and low-dose steroids, the child now appeared more active, ambulating, and playful. His left rectus palsy was also corrected with near complete resolution of proptosis. As you can see in the picture, first picture 1 after 40 days of therapy and picture 2 after 60 days. Follow-up after 6 months, here you can see the child is able to abduct very well. Cavernous sinus thrombosis presenting with only proptosis and unilateral 6-nerve palsy in a child is rare, with very few cases reported in literature. So in our case report, the child was initially treated for anaphylactic shock. His initial CT was normal. His general condition was not improving. After ophthalmic examination, we advised for a repeat CCT, which dramatically changed the treatment, and he showed improvement. So I'd like to conclude by saying a high index of suspicion for ocular signs like proptosis presenting with fever is necessary. Current era antibiotics and anticoagulants have reduced the mortality due to cavernous sinus thrombosis. However, the morbidity due to the disease remains. A multidisciplinary approach between the ophthalmologist and other specialties is required to combat the same. These are my references. Thank you.
Thank you so much. Excellent presentation. Paucity of time. We're going to go to the next presenter. We'll discuss it later. So may I have Lakshmi, Dr. Lakshmi S. on the podium for painful monoocular vision loss by idiopathic inferior rectus hematoma. I would request the presenters to be in the first line so that we can quickly do it. Yeah. Can we have Lavanya on the other podium so that you're ready and we can do it quick, Lavanya? Ready on the other side.
Good afternoon, everyone. Today I'll be presenting a rare case of painful monocular vision loss. 30-year-old male patient presented to our outpatient department with sudden onset of loss of vision of left eye for past 3 days. There was associated history of pain and photophobia. There was no history of trauma or any other systemic illnesses. The patient did not give any significant drug history. On ocular examination, his visual acuity was 6/9 on right eye, and left eye there was absent perception of light. On external examination, there was mild protrusion of the eyeball of the left eye. The right eye had normal findings. Cornea, anterior chamber, and iris showed normal findings. Apart from that, pupil showed grade 1 relative afferent pupillate defect in the left eye, while the right eye showed normal shape and normal reaction. Lens was clear on both eyes. The intraocular pressure of the left eye was raised compared to the right eye. On fundus examination, there was cupping on both the eyes. Apart from that, there was tortuous vessels on the affected eye. Patient was then admitted to our inpatient department and underwent an array of investigations. His routine blood investigation was within normal limits. The coagulation profile was also within the normal limit. MRI brain with orbit was done using contrast and plane, which showed a well-defined type 2 hyperintense and type 1 hypointense lesion in the extracorneal space in the inframedial aspect of the left orbit. The lesion was encasing the inferior rectus and extending to the medial rectus and posteriorly to the orbital apex. The lesion shows enhancement on administration of the contrast. The lesion appears increased with Valsalva maneuver, and the lesion measured around 14 by 18 by 5 millimeter. There was thinning of the left optic nerve noted. Patient was started on eye drop timolol and tablet vitamin B complex on admission, and after examination on studying the MRI findings, the patient was then referred to higher center and was planned for surgical drainage. Thank you.
Thank you very much for an excellent presentation. We'll do the discussion later. Yeah, thank you so very much. So over to you, Dr. Lavanya. Can I have Dr. Harsha on the other side of the podium? Thank you.
82-year-old gentleman presented with the complaints of protrusion of left eye associated with pain and drooping since 3 days. He was already under oral amoxicillin clavulanic acid treatment when he presented to us. On examination, his visual acuity in left eye was 20-30 parts and right eye was within normal limits. In left eye, there was periorbital edema, conjunctival congestion and mild proptosis. Extraocular movements were limited in all cases. CT orbit showed ill-defined isodense shadows in the left orbit, which is more towards the ocular coats. So the patient was treated with IV antibiotics and paracetamol, and after 24 hours of antibiotics, there was clinical resolution. So he was started on dexamethasone low dose. After 3 days of this treatment, there was clinical resolution of all the symptoms and extraocular movements were full. After 5 weeks of resolution of previous symptoms, this time the patient presented with swelling, pain and drooping of upper lid in right eye, but this time there is no chemosis and no congestion. There was a proptosis of 2 millimeters. And clinically the extraocular movements were limited in all cases. CT orbit showed dilated superior ophthalmic vein and a soft tissue densities in between the medial rectus and the globe. MRI orbit showed ill-defined hypointense abscess in the right orbit between the eyeball and medial rectus and a dilated superior ophthalmic vein. Sorry, the images are not available. So with the provisional diagnosis of right orbital abscess with superior ophthalmic vein thrombosis, the patient was advised to take a neurologist consult to start on anticoagulants and the cause for the thrombus formation in superior ophthalmic vein. After starting anticoagulants, initially there was resolution of symptoms. However, on day 4 of the same treatment, there was exacerbation of symptoms and patient presented with severe pain and swelling. So he was started on low dose steroids along with the antibiotics and anticoagulants. He showed improvement in terms of extraocular movements and proptosis. However, he developed secondary glaucoma, for which we added topical and oral anti-glaucoma medication. On subsequent follow-ups with the same treatment, there was resolution of the symptoms and patient improved. Till after the resolution of this episode in the right eye, patient was followed up with the physician. He has finished the course of anticoagulants and systemic workup was done, which was normal. 2 weeks later, he again presented with the same complaints in the left eye. So now a hypocoagulable state versus the infective thrombus dislodged from the distinct site was kept in the mind and reviewed history. However, he has a history of multiple ulcers and the GI endoscopy was done, which was due to the H. pylori infection. He was advised to take gastroenterologist consult and immunologist consult. So the gastroenterologist told that H. pylori cannot cause an infective thrombus elsewhere. The autoimmune profile was within normal limits and he has completed the course of anticoagulants and he has no active eye infection. However, after 6 weeks, he was diagnosed with an interstitial lung disease for which he was kept on immunosuppressants, and in the subsequent 2 years of follow-ups, he has no evidence of eye infection. So the take-home message is, in any case of orbital cellulitis, we should check for the superior ophthalmic vein dilatation or the thrombus, and if there is a thrombus in superior ophthalmic vein, we should always rule out whether it's infective or due to hypocoagulable state.
Thank you very much. So he might have an attack again, probably a repetition.
This time he is on low dose immunosuppressants.
Okay, all right.
That's why he is not developing anything. Previously they just gave anticoagulants during that episode of cellulitis.
Okay.
After third episode they kept him on continuous immunosuppression.
Perfect. Thank you so very much for 2 cases contribution. We go on to the next speaker, Dr. Harsha Chandran, IgG4, the new kid of the block.
Good afternoon to everyone on and off the dais. My topic is IgG4, the new kid on the block. I am Dr. Harsha Chandran and my guide is Dr. P. Modini. IgG4 is a multi-organ fibroinflammatory disease with tumefactive lesions of unknown etiology. It is associated with elevated levels of serum IgG4, and the hallmark of this disease is a dense lymphoplasmacytic infiltrate with IgG4 positive plasma cells. Due to a lack of systemic approach, this disease is usually underdiagnosed, and the predominance is more in older males in the 6th decade, with the most common organs involved being the pancreas, the kidneys, the orbital adnexal structures, salivary glands, and the retroperitoneum. The orbital and ocular manifestations include lacrimal gland involvement, a painless unilateral or bilateral proptosis, periorbital swelling, erythema, and all. The 2020 revised comprehensive diagnostic criteria for IgG4 related diseases have 3 points: clinical and radiological features, a serological diagnosis, and a pathological diagnosis. The clinical and radiological features were consistent with the swelling of any organ, one or more, serology showing higher IgG4 levels, and a pathological diagnosis. The materials and methods involved in this case, there was a 40-year-old female who had presented to our OPD with complaints of outward protrusion and periocular swelling of the lids of both eyes for 2 years. It was gradually progressive and painless in nature. She also had noticed swelling in the parotid and neck regions at around the same time. She is a known case of hypothyroidism on treatment with thyronol 50 microgram for the last 5 years. There is no other significant history as such, and since general examination had showed a swelling in the sublingual, submandibular and bilateral parotid regions, an ocular examination showed that both eyes were proptosed with diffuse periorbital swelling and a best corrected visual acuity of 6/12 in both eyes. Anterior segment and fundus examination was within normal limits. Extraocular movements were full and free with Hertel's ophthalmometer readings of 24 mm in the right eye and 23 in the left eye. The patient had presented to us with an MRI film which had showed thickened recti, oblique muscles and bilateral proptosis, and this had been done outside. So based on the clinical findings, a professional diagnosis of Mikulicz disease, IgG4 disease and non-specific orbital inflammatory disease were made. Lab investigations were done and which showed elevated levels of IgG4. Eosinophilia was noted on the complete blood profile. Mantoux test was negative. The thyroid profile was normal and no abnormalities were detected on chest X-ray. Further, an FDG PET-CT was advised to look for any other active foci of inflammation or the disease, and it showed uptake in salivary glands, cervical, mediastinal nodes, lung changes, and foci in the pancreas also. So sublingual gland biopsy was done under LA, and histopathology revealed tiny fragments of stratified squamous columnar epithelium, which was consistent with the mucinous gland. And the diagnosis was IgG4 related disease was made. The patient was started on glucocorticoids like 10 tab prednisolone 15 mg per day, and she was referred to a rheumatologist for further evaluation. So after 1 month of steroids, the periorbital swelling and proptosis had come down. So IgG4 related disease is a unique clinical entity, and thorough evaluation is required for us to reach a diagnosis. Clinching a diagnosis of IgG4 related disease is often challenging due to subtle and varied ophthalmologic and systemic presentations, which will be missed if we don't look for it. And we have also sent the blocks for an immunohistochemistry because we couldn't find any IgG4 positivity in those samples. Thank you.
Thank you very much. Very well documented, and you have worked up the case so well, and that's why you could actually target the disease. So one thing that I would really want to say is that they usually present with very painful, IgG4 is usually painful IOID. Did this patient have severe pain?
She didn't complain of any pain of such.
All right.
Yes, ma'am. And it's been over 2 years, so I don't know if she had pain in the beginning or not. She has not complained of any pain as such.
Okay, very good presentation. Thank you so very much. And we're going on to the last presentation. We have Dr. Amit Prasad P. 1 + 1 free. Areva, that's a nice way to end.
Yes,
all right.
They haven't put the presentation. Yeah, ma'am, ready. Yeah, good afternoon everyone. I am Dr. Amit Prasad, a junior resident from Osmania Medical College. My guide is Dr. Modini. The title of my presentation is 1 + 1 free. So I'll be talking about dermoid cysts, which is one of the most common orbital tumors in children. It accounts for 46% of all the childhood orbital neoplasms and accounts up to 3 to 9% of all orbital masses. Of these, 24% are superficial, 6 to 8% are deep, and 80% of them are cystic orbital lesions. Though about majority, that is 94% of all the ocular dermoids are lateral, we often tend to see medial dermoid cysts as well. So today I'll be talking about a special case of a first and only case in the world of a twin dermoid. Mind it, it's not a deep-seated double dermoid or dumbbell-shaped dermoid, but a twin dermoid. I'm going to explain on it further. So it was a 3-year-old boy who was brought to the OPD with complaints of swelling noted near the medial canthus of the left eye, adjacent to the nasal bridge for 6 months. The swelling was painless, gradually progressive in nature, and not associated with any other complaints. No other significant history was elicited, and general and systemic examinations were within normal limits. On ocular examination, visual acuity was 6/6 in both eyes on Lee chart. On inspection, ocular symmetry was lost because of the fullness noted in the left medial canthus and also mild mechanical ptosis in the left eye. A swelling with well-defined borders measuring up to 1 into 1 centimeter was noted extending from the lid crease to the left medial canthus in close proximity to the medial orbital wall. On palpation, all the inspectory findings were confirmed, and it was a single immobile mass but with boggy consistency. The skin of the swelling was smooth and pinchable, but the posterior border could not be felt and trans-illumination was negative. So a CT orbits was done as a preoperative evaluation to rule out any bony involvement. But it showed a single round cystic lesion, but owing to its boggy consistency, trans-illumination negative, and a posterior border not being felt, we wanted to rule out a vascular involvement, so we had done a CECT orbit, which also showed a single round non-enhancing lesion. So a provisional diagnosis of a dermoid cyst was made and a plan to excise under GA. So this video, it shows that the first, initially when we started the surgery, we had removed the dermoid. It was completely excised, and just before closure, we had noticed another smooth globular structure lying right beneath it. So on further dissection and separation, we had noted that it is an entirely separate dermoid, which is a completely different origin and has no connection with the first dermoid. And this was later excised, and both these samples were sent for HPE. On histopathological examination, both the cysts showed a similar picture of a cyst lined with stratified squamous epithelium with giant cells, and cyst lumen showing lamellated layers of keratin, and cyst wall showing pilosebaceous units. This confirms the diagnosis of a dermoid cyst for both the swellings. So a case as such, like twin dermoid with no connection between the two, is quite an exciting find, and it has never been reported ever in any international platforms. On looking back, we had noticed that both the radiologist and ophthalmologist have missed out a classic finding on the CT and the CECT. So this might be, this can be overcome by, I think, doing an extensive study, extensive investigation and careful examination of the patient in the future. And definitely these cases like this add spice to our oculoplastic journey. And this is the patient 1 month later with a very good cosmesis. Thank you.
MRI was not done.
MRI was not done. We were not suspecting any intracranial extension. So, with any smooth, like it clearly showed in CT as a single non-enhancing lesion, so we were okay with that.
Ma'am, CT I think is good enough for a benign lesion, and when it's clinically excellent. Yeah, I have never seen something like this before. Yeah, it's like take one, get one free.
Yes, ma'am.
Thank you so very much, and apologies to the glaucoma team, and thank you to the chairperson and the co-chairperson of the glaucoma for allowing us to get all our presenters present. Thank you so very much for your patient listening. Over to you, Dr. Vanitha. Thank you so much. Thank you, ma'am. Thank you so much, and thank you very much.